Good afternoon, and thank you to CAR and the Conference Organizing Committee for having me. I'm so happy to present this work on behalf of my co-authors and colleagues who I've listed on the left here, and I nor my co-authors have any conflicts of interest to declare. Before I begin, I want to recognize that the work I'm presenting today was conducted in Winnipeg on Treaty 1 territory, and the Manitoba HIV program has clinic sites on Treaty 1 and Treaty 2 territories. These are the original territories of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and the homeland of the Métis Nation, all of whom have called this land home since a time long preceding the arrival of settlers like me. So despite evidence of unique HIV epidemiology in the prairies compared to the rest of Canada, and relatively high rates of new HIV infections annually, literature focusing on HIV in the prairies is quite limited, and there's a specific lack of research focused on Manitoba. Currently, most available data on HIV epidemiology in Manitoba comes from annual surveillance reports by the Public Health Agency of Canada or Manitoba Health, both of which are limited in their ability to shed light on longitudinal trends in HIV care or clinical outcomes. However, in 2013, CIHR funded a multi-site program of research called the LIVE Study, led by Dr. Claire Kendall at the Briere Research Institute in Ottawa. It was through the LIVE Study that Manitoba received support for establishing a prospective clinical cohort of people living with HIV in the province. And this cohort is the first comprehensive source of HIV-specific health data in Manitoba. For a complete description of our cohort, I'll direct you to this paper, which we've published in BMJ Open at the end of last year. Then, using data from the clinical cohort, we were able to develop the first and the most comprehensive HIV care cascade model for Manitoba through an iterative consultation process with key stakeholders. We also generated local estimates for each cascade step using cohort data. For more info about the process of developing the Manitoban Cascade, you can check out our publication in the Journal of Clinical Epidemiology. And I just wanted to show the final cascade model that we developed with estimates from cohort data in 2017. This cascade is the baseline model upon which the equity analyses I'm about to present were based. Before I get into the results, I quickly wanted to talk about why we thought it was important to conduct equity analyses on our cascade. So as we all know, a cross-cutting theme of the Sustainable Development Goals is equity and the idea of leaving no one behind. As such, there is an imperative for public health research to focus on health equity. Conventionally, cascades have been created using aggregate data that illustrates engagement in care across an entire population. But this approach runs the risk of obscuring heterogeneity that exists within a population. Examining the cascade through an equity lens by using disaggregated data to construct cascades for different population subgroups is one strategy for better understanding inequalities that exist across the cascade. And then more recently, we are beginning to see disaggregated cascades coming out of a number of jurisdictions, which is really promising. So for this study, the first step was to identify relevant equity variables by which I would ultimately disaggregate the cohort data. These included a variety of variables on sociodemographic characteristics and reported HIV exposure categories. Two complementary analysis methods were used to examine these data through an equity lens. First, I used equiplots to visualize inequalities between participant subgroups in each step of the cascade. Equiplots were a relatively new data visualization and analysis tool that were developed at the International Center for Equity and Health in Brazil. They're perhaps best known for being used to demonstrate inequalities in a variety of country-level indicators that are measured for the Countdown to 2030 initiative. Today, though, I'm presenting a novel use of equiplots to examine inequalities across the HIV care cascade. And then second, to complement the equiplots, I ran multivariable logistic regression models to quantify the observed inequalities and infer statistical significance. I'll just take a few minutes to present select equity analyses that highlight the potential utility of equiplots as knowledge translation and data visualization tools. For a more comprehensive overview of all of the equity analyses we've done, we have published a paper in BMC Public Health that you're welcome to check out. Okay, so on the left is an equiplot illustrating the Manitoban cascade data disaggregated by age. We have each step of the cascade represented as a tick along the y-axis, and the percentage of people in each step as a proportion of the alive and diagnosed step is tracked on the x-axis. The age group categories are each represented by different colored markers in the figure. We see a pretty clear and almost linear relationship between age and the progression along the cascade. So the relative proportions of participants in each step are increasing with age. In particular, we can see that the youngest age group is substantially underrepresented in each cascade step here. Once we visualize these inequalities with the equiplots, we can then turn to the table on the right here, which is depicting results from a multivariable logistic regression model to determine whether these inequalities, when quantified, are of statistical significance. We see that compared to the youngest age group, participants who are 40 and older are significantly more likely to be in every cascade step. Meanwhile, participants in the 30 to 39 year age group have almost 2.5 times greater odds of being retained in care compared to the youngest age group, but statistically they are no more likely to be in care, on treatment, or virologically suppressed. Here we're looking at the data disaggregated by geography. Most notably, we see that the participants living in eastern Manitoba are doing pretty well compared to those in other regions, and there's really very little leakage or drop-off between cascade steps for this group. Meanwhile, those living in western Manitoba appear to be less engaged in care in the earlier steps of the cascade, but do not differ much from other geographies in terms of virologic suppression. We can also see this drastic drop here in engagement at the virologically suppressed step among participants in southern Manitoba. Our regression analyses in the table on the right suggest that the odds of western Manitoban participants being in care are 1/3 that of Winnipeggers, and eastern Manitobans are nearly 4 times more likely to reach virologic suppression than Winnipeggers. So I think these geographic analyses highlight some of the complexities that we need to pay attention to when we're so used to relying solely on statistical inference to determine whether patterns or trends are significant, particularly when we're thinking about programming. What I mean is that, for instance, even though we can see in the equiplot quite clearly that there's a substantial drop-off in the proportion of participants in southern Manitoba reaching virologic suppression, this is not captured as a statistically significant finding in our multivariable models. Noting these discrepancies in our analysis methods is important to keep in mind, particularly when we're thinking about programmatic or policy implications of these findings. This is my last example. Here we've disaggregated our cascade data by ethnicity, and we can see that relative to all other ethnicities, white participants are most engaged and comprise the greatest proportion in each step of the cascade. In the in-care and retained-in-care steps, we see relatively low representation of African, Caribbean, Black participants and those in the other ethnicity category, but then in the virologically suppressed step, Indigenous participants comprise the lowest proportion at about 65%. When we statistically compare participants in each ethnicity category to white participants, we find that Indigenous folks have significantly lower odds of being retained in care, on treatment, and virologically suppressed, whereas those identifying as African, Caribbean, Black are less likely to be in care and retained in care. In this case, these findings do quite closely reflect the inequalities that we can visualize in the equiplot. What I wanted to highlight from all of this is how useful equiplots are for drawing our attention to points along the cascade at which specific groups are unable to optimally engage in HIV care or reach target health outcomes. While regression models highlight specific inequalities of statistical significance across the cascade, my work is demonstrating that equiplots are useful knowledge translation and data visualization tools for identifying inequalities that, although not statistically significant, may be programmatically relevant and should be taken into consideration during program planning and design. So what now? Since its development, the Cascade has been used to guide and influence international HIV policy. However, building upon other researchers' arguments, the work I've presented here today suggests that this framework, when used as an analysis tool, does not provide enough granularity or context to adequately inform policy decisions, nor to inform program design and implementation. A more thorough and responsible approach to develop policies and programs that align with principles of health equity should involve additional methodologies that can shed light on the reasons why inequalities exist along the cascade and the mechanisms and systems that act to perpetuate them. These quantitative analyses that I've presented are an important starting point to examine equity issues along the cascade, but alone they do not provide sufficient context or explanation for leakages along the cascade. In order to appreciate nuances here and understand, for example, why people are having a hard time engaging in their HIV care, complementary research approaches, namely qualitative inquiry and community-based participatory research, will be crucial in generating evidence that can provide the context that's so important during the development of effective and supportive programming and policies for HIV care. And that's it. Thank you. Happy to take questions.